So I'd now like to introduce our first speaker. We've got Mr. Michael Fay. He's the Nurse Manager in Clinical Practice Leadership with Hunter New England Health Service, and his presentation is Excellence in Patient Care Essentials. Thanks, Michael.
Good afternoon, everyone, and thanks, Ingrid, for the welcome today. Thanks for the opportunity for joining me for the next 8 minutes. I would just like to just give you a brief introduction to Hunter New England. We are a large local health district. We're made up of 7 sectors. There are 38 facilities, 1 a tertiary referral centre and a number of base hospitals. We have 12 multi-purpose services and we provide care to over 950,000 community members. Over 50,000 of those are Aboriginal and Torres Strait Islander people. And I would like to acknowledge our executive sponsors, my colleagues at Nursing and Midwifery Services, and our Hunter New England health staff. So just moving here, why was this a process that H&E pursued? This has been a 10-year journey. Really our why, it's about caring for our community, our family and our people. How we do it? It is by providing a consistent process and a framework which I will talk about, which is the evidence-based leadership framework. To ensure that our practices are consistent, we reduce variability and ensure that practice is contemporary within this space. And what we want to achieve out of this, safe care for every person, every time. So this is a broad picture of our evidence-based leadership framework. It's made up of 3 components: aligning goals, behaviours and process. What you can see here certainly is the importance of our executive sponsorship, our leadership, our role modelling and our accountability. When we look at our aligning behaviours, it's really important to look at what we must have, and this is our Patient Care Essentials bundle. And as you can see there, a number of other components. And aligning our process, so ensuring policy, governance, procedures, education and alignment is key. So what are our patient care essentials? I'm going to be talking about a number of these today. In summary, this is inclusive of our patient safety briefing, our communication techniques, which include HADIT and ISBAR, intentional hourly rounding, care boards, clinical handover at the bedside, safety huddles, and our follow-up phone calls after hospital. Important to note that each of these elements are governed through associated policies, procedures and guidelines. The Patient Care Essentials align with the National Safety and Quality Health Service standards, and these standards provide a nationally consistent statement of the level of care consumers can expect from the health service. So a little bit about hourly rounding and how it's applied in practice in Hunter New England. Our why? Really important. This is proactive and it's purposeful. And what we do know and what the evidence does tell us, when done so, it reduces falls, increases satisfaction, and reduces our call bell use. How? This is really important, and applied is our P's and D's. So that's incorporating our personal needs, our positioning, our patient environment, discomfort, devices and documentation. What you can see here, this is a proactive, structured process for the clinician to purposefully engage with the person, with the resident, with the carer and their family. Moving through to our care boards, there are a number of care boards outlined. We have a range that meet the subspecialty requirements across Hunter New England. What we do know, our why around this, poor communication in healthcare can have serious consequences for patients, and it can lead to errors and delays and variability. The care board is a tool. It's positioned near the patient's bed and used to improve communication between the patients, the carers, the families, and members of the multidisciplinary team. And the goals are prioritised, the plan of care and the patient's questions and concerns, and can be written on a patient care board and include staff members' name involved in the care. When we look at our clinical handover at the bedside, our why around this, it's putting the person at the centre of why we're here as a multidisciplinary team. How this is utilised, it's incorporating our communication strategies, which is inclusive of our H-AIDIT and ISBAR format. And the outcome, this is the transfer of the responsibility and accountability for that patient to another clinician team that's in attendance and involving the patient or carer in this process. Safety huddles in Hunter, New England, our why. So our safety huddles reduce the number of clinical incidents in facilities where they're practiced consistently. They've also been shown to increase staff wellbeing and morale as they improve their teamwork. How? So safety huddles in the inpatient setting generally occur at electronic patient journey board and can be conducted at regular intervals in response to an event and more frequently. We have introduced a number of post-incident huddles which can occur most safely, potentially with the person and carer and the broader MDT. So how it's conducted, it's a structured process consisting of a brief stand-up meeting that lasts no more than 5 to 10 minutes. It's multidisciplinary representation and it's designed to flag those high risk and most importantly putting in those mitigating strategies to prevent risk for that next hour, 4 hours, 8 hours and beyond. So I'm just going to summarise. This is our commitment to our people, to our community, and it is working with our multidisciplinary team to facilitate best practice. Excellence seeks to ensure that care is consistent, safe and compassionate across all of our services, to reduce the variability and improve reliability. As an organisation, when we align our goals, our behaviours and our process, we move forward together. We've consistently applying these principles of excellence, including our patient care essentials, improves our patient outcomes and experience. We've seen this with our nurse-sensitive indicators and our hospital-acquired complications rates. And I'd like to thank you for this afternoon. Thank you.
Thanks, Michael. Does anyone have any questions in the room? Yes, there's one down the back there. I'm going to do... Yeah, that'd be amazing. Thanks, Cameron.
Thank you very much. Hi, Michael. I just wanted to ask, how do you evaluate your interventions and make sure that you maintain their fidelity over time?
Yeah, absolutely. So we have been on this journey for a little while. So we have actually partnered with consumers, with our clinical governance. I suppose where we started a number of years ago was more so clinical guidelines to obviously facilitate that practice. We've now moved to policies. It now forms part of our district audit schedule for our accreditation, in particularly for Standard 1, 2 and 6. And certainly our operational teams, it does actually form that evidence for our 8 standards. Thank you.
Great. Thanks, Michael.
Thank you.
Thanks, Michael. Okay, we'll move on now to the next presentation. We have Ms. Melina Pessin, and she's presenting on 3A, Transforming Your Experience, a multi-approach to reduce top 3 clinical risks from Bankstown and Lidcombe Hospital. Thank you.
Thank you. Sorry, I'm a bit short. Hello, so my name is Maylan DePexet. I'm a nurse unit manager at a surgical ward in Bankstown Hospital. And we've been working on this project for the last 3 years. So we named it 3A Transforming Your Experience multi-approach to reduce top 3 clinical risks in our department. So I want to thank our sponsor, Linda Campbell. She's our Director of Nursing for Bankstown Hospital. And my clinical nurse educator, Debbie Collins, whom without her, this project would have not been possible. There we go. So the reason why we started this project was that we gathered data in 2020 when I took over the ward, and we realised that there was a high increase of clinical risk incidents that were leading to really bad consequences, including harm score 1 and 2, which was, patients ended up with a fracture, which they had a fall, ended up with a fracture needing a surgical procedure intervention, or at the worst case scenario is death. So as you can tell, in 2020 we had 48 falls, we had 23 hospital-acquired pressure injuries, and we had 17 medication administration errors, and a total of 192 clinical incidents in 2020. So our project aim was to really reduce our top 3 clinical risks, which were our falls, hospital-acquired pressure injuries, and medication administration errors. So we came together along with the Transforming Your Experience team for Southwestern Local Health District to include safety essentials. So if you're part of the Southwestern Local Health District, we do have 7 safety essentials, but we decided to make it practical for the ward, and we realised that not every safety essential was going to be able to be implemented within a surgical department, so we only chose a few of those. The change ideas behind it was we started to do a lot of focus groups, which involved all of our nursing staff, multidisciplinary teams on what it needed to change. So staff realised that we needed to work smarter, not harder. We also had, obviously, the leadership support of myself being heavily involved in the implementation, and so with the clinical nurse educator and the executive team. And then we will update on a monthly basis about our clinical incidents rates to the nursing staff, so they will be aware of what was happening in the ward. So we decided to implement only a few of the safety essentials. So the main ones were our risk huddles, our proactive patient rounding, which is done with our hourly rounding. So risk huddles are definitely one of the things that make such a difference. So we all get together every day at 3 o'clock, and that's a template that we actually use, and we use it for recording purposes. As you can tell, we tackle a variety of clinical risks, including work health and safety as well. And we talk about what the risks are for the day and the strategies that we're actually gonna implement to make sure our patients are safe. And in 2021, we obviously came back to gather our data to see if the safety essentials and the way we implement and roll out our framework worked. And as you can tell, in 2020, so I'm gonna send here, our medication administration errors actually went from 17 to 9. Our hospital-acquired pressure injuries in 2020 went from 23 to only 7. And our falls had a big impact. So we went from having 48 falls a year to only 10. And that was in 2021. So we wanted to use 2022 as a maintenance year. So to see if whatever we had implemented in 2021 actually was sustainable and was now embedded in the ward. And you can see the results in 2022. There was an increase in clinical incidents, very slightly because of COVID. But you can see medication errors maintain 8. Hospital-acquired pressure injuries only slightly went up to 11. And our falls went up to 19. And then when we looked into the data was because we're putting a lot of our COVID patients into single rooms with the door closed. And by the time the staff were putting the PPE on and getting to the patient, was unfortunately late. But we've been able to demonstrate that applying Transforming Your Experience Safety Essentials have actually worked in a surgical ward. Lessons learned and next steps. So learning to celebrate small wins, because I think we were about let's implement and move on, and we didn't really take the time to celebrate that we were making such a big difference in every single patient that came through those doors, which was the main thing of implementing these strategies. And what's next? We do have patient care boards, which they have been around for a long time, but I think what we want to focus is making it useful for the patient and also for the nursing staff. So it's not only about compliance and achieving 100% in our clinical audits, but it's actually making it useful and meaningful to our consumers and also to our staff. Sorry, I think that, well, anyways, that's it of my presentation. Sorry, this remote's not working with me today. Thank you.
Thank you for that presentation. I think you've demonstrated some amazing results, and I think it's around communication, isn't it? It's communicating risk, it's communicating strategies that you're putting in place, and it's keeping that communication going, shift to shift to shift. I really enjoyed that, thank you. Does anyone have any questions? Yes, up the back there. Sorry.
I'll just speak out loud. I'm more interested in how you implement the focus group for your nursing staff.
Yep, so on a weekly basis, we've got about 16 nursing staff when they overlap between 1:30 and 3:30. So we utilise that time to actually get most of our staff. And there were times where we only did, let's say, senior staff and junior staff, just to compare sort of the expectations from, the older nursing staff that have been around for a long time, where change can be sometimes a bit more resistive as opposed to our newer staff. And then we just took feedback. So an example of, they never had race huddles. They used to do patient journey board between 1:30 to, I think it went over 2 o'clock. But the problem with that was, it was great to see they were talking about patient handover, but they, A, were not doing it at a patient bedside, and B, they were not talking about clinical risks. And I think when we shift to risk huddles, which is focusing on the clinical risks for the days and for the type of patients that we actually have right there and then, and implementing the strategies, I think that's what really made the change.
I would agree. And I think, we see so many of those journey board discussions and we highlight that a patient's at risk of falls or a patient's at risk of pressure injury, but really any older person in hospital is at risk, has those risk factors. So I think communicating what they are and how you're going to prevent them on that shift or things you go to strategies is really important. Thank you. Could we just get the microphone to Michael? Michael, sorry, you just had one question on Slido here, which I missed, so I will ask it now. We have a bit of time. Michael, it was around your safety huddles, and it was how often do you run your safety huddles, and how did you get the multidisciplinary team to attend them?
Yeah, sure. Hi, so safety huddles. So our policy compliance procedure, the minimum is safety huddle once in 24 hours, determined locally by the clinical service. So essentially what we're seeing in practice, there's a safety huddle that occurs every shift. And that's generally led by the manager or delegate. And with regards to our multidisciplinary team, certainly in our tertiary centres, we do have good representation. For our rural and regional services, there are limitations because there is not the number of allied health staff and medical. We have virtual medical support. But yeah, certainly the engagement more broadly has been fairly well accepted.
Great, Thank you. Next up, we have Greg Hayes from Hunter New England, and Greg's the Initiatives and Project Coordinator of Nursing Midwifery Services in Hunter New England, and Greg's talking about a safe toileting strategy, reducing unwitnessed falls in the bathroom.
Thank you and hello to everyone. Happy afternoon, and hope you all are enjoying the forum. So I get to, I suppose, pick the short straw or long straw around presenting around safe toileting strategy within Hunter New England. And while it might sound a little bit silly, it's actually quite, a serious topic, particularly when the percentage of incidences that occur around a patient falling from an inpatient perspective, whether it be at the bedside, mobilising to the toilet, or in the toilet itself as well. So how did it start? Well, it really, in 2020, there was a bit of a district guideline that was developed, and it was called Falls Prevention Safe Toileting, and it was really based on risk identification at a local hospital that aimed to address some unsafe practices around toileting. So the clinical guideline identified the risks of falls, hacks, dignity, injury to staff and patients and carers, increased length of stay, and also the risk of intra and inter-facility hospital transfers. So the guideline really set out to minimise these risks by making sure we use the correct and appropriate toileting devices, the safe use of those devices, purposeful rounding and assessment for toileting plan, but also around that correct supervision of the toileting device. Initially, this sort of strategy wasn't seen as a strategy, but it very much developed into it. And because when Hunter New England stopped and had a look at the data, particularly from IMS Plus when it was rolled out, we could identify that over a 12-month period, 22% of falls occurred in the bathroom. And of those falls, 71% were unwitnessed. So that was really identifying the need for increased supervision around that space, and making sure too that the equipment was used correctly. So the developing strategy at this time had recognised the potential to reduce 550 unwitnessed falls per year, or 46 falls a month. And in comparison, when looking at Hunter New England, we average around 310 falls documented a month. So what is it? How do we get the golden toilet, or how do we move towards the golden toilet? So the first step is really around that risk screening, care plan and FRAMP documentation, and it's really around the process. So we had to make changes to at least have a space to clearly document a toileting schedule or toileting plan for our individualised patients, making sure that they're assessed on admission and also reassessed, and making sure that when we do use devices that they're documented, that they are for use. The next one is around that education, so influencing that behaviour, trying to stop and change unsafe practices occurring. So the first one's around that inadequate supervision, so leaving them alone in the bathroom, or the unsafe equipment use. And I really ask everyone in the room, reflect on your own practice and your own experience. I think in the first couple of years of myself practicing, giving a gentleman a bottle at the bedside, and he was insisting on privacy. So I'm there trying to give him privacy, but peek through the curtain as he sort of stands there with a bottle, tries to be, so you do reflect on your own experience. Another one is around the commodes and leaving commodes there at night, or using bedpans inappropriately, so either putting them on the bed or on chairs, depending where the patient is. So really focusing on that correct use of equipment. Making sure our hourly rounding that's been in place for quite a while had a space to be more proactive and maturing that documentation, and making it a normal part of our shift planners in creating that awareness. Partnering with our consumers, so really embedding, and that goes back to a little bit around that care plan, around our goals of care for our patients, and having them involved in what matters to them and how they want to be seen and involved in their toileting as well. And of course, communicating for safety, whether it be the bedside handover or the safety huddle. And one of the big successes that we've spoken about today is our safety huddles, but even having an e-form to influence around what is discussed at a safety huddle and who is present as well. So then you have a bit of a documentation process without taking away the purpose of it. And particularly from a safety huddle perspective, not highlighting who's just at risk, but what strategies are in place is a big part, because who's at risk on a medical ward? Every single person in that ward generally. So it's really making sure we discuss that core business for that particular clinical area. So key messaging and targeting education. So the first one is a video that we developed. From a 12-month, bit over a 12-month point of view, it's been viewed 560 times in the sense of used in services and education. But ultimately, we added it to My Health Learning with a quiz, 4 or 5 questions behind the quiz as well, just to link with the learning outcomes. From April last year, we've had over 1,000 that have self-enrolled or the manager has enrolled. But actually this month, we ended up having to pin the education just to make sure we get a broader audience, which has increased, has added an additional 1,300 within that space. And getting that key message out from a safe toileting perspective, the benefits of being on a paper system still is that you can get a pen. And it's really good currency when you're connecting with staff as well. These pens have been quite successful in at least creating a bit of a discussion, and they've actually been extended to both midwifery and also pressure injury areas. But it was just such a simple idea around engaging with our staff and what may or may not be value to them, to then get them discussing safe toileting. And this pen has key messaging around supervise, 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 and particularly those equipment use that we've spoken about before. Are we making a difference? So I've got a data source up there just for those interested in how we're measuring our safe toileting strategy, and it's around calculating the total falls within the bathroom from an IMS perspective, and then applying that unwitnessed aspect to it. So if we average 2021, we're looking at 69% of falls in the bathroom are unwitnessed. Last year, it went up slightly to 72, and this year we are trending down to 68. So while there hasn't been a huge significant change within our data, we do recognise the pressures from last year, and that we have maintained consistency as well. And from a point of difference, the New South Wales state do have a rate of 73. So it's just looking at that. But one of the big things about data is be mindful to not compare apples to oranges. It's really, really important. So the data that I previously presented was a district, and our district is massive. But when you stop and have a look at conversations and engaging with services, from a facility A point of view, one might be sitting at 80% of unwitnessed falls, or a facility that is an apple likewise, might be sitting to 60, 65. So sometimes it helps conversations around how, and it might be even the ward layout as well, from a medical ward, might be sitting at 88 or 68 as well. So my question I leave with you guys today is, do you know your data around safe toileting, and do you have a high rate of unwitnessed falls in the bathroom as well? There is no silver bullet, as we all know, and it takes lots of multi-steps and multi-aspects to sort of work towards a strategy and also reducing falls. A few extra steps that we're looking at is trying to help that process around measuring safe toileting, continuing to influence culture around safe toileting, rounding and engaging as well, but just keeping up that awareness and discussion around safe toileting as well. I have got a QR code up there in regards to if you'd like to get a copy of the safe toileting video, and I've also got a QR code up there from a safe toileting guideline point of view. There are some pens at the back with my colleague Mel, and there's also some pens at the front if you'd like to steal a couple, because everyone loves a pen. But I will end this presentation just with a video, if that's right. Thank you so much.
Delivering person-centred care improves the patient experience and may prevent harm. There is a significant risk of patient and staff injury when toileting aids are used incorrectly or unnecessarily. A number of patient falls within Hunter New England Health are related to the toileting process. All patients on admission must be assessed by nursing staff for their toileting needs. This should be attended in collaboration with the patient and the clinical manual handling program.
Morning, Cheryl. How are you?
Pretty good, thanks.
My name's Judith. I'm your nurse today. I believe you're going to surgery today?
Yes.
After your surgery, when you come back to the ward, toileting might look a little different for you, so we may use a bedpan. So I just want to let you know about that.
Oh, thank you.
Toileting needs should take into account the patient's continence, available and required equipment to promote safe patient toileting. This also includes checking the surrounding space for potential hazards. Any toileting needs or necessary changes should be included in the bedside handover, and staff are to ask the patient if they need to go to the toilet as part of purposeful hourly rounding.
Hi Cheryl, how are you going?
Pretty good, thanks.
It's good. How are you feeling after your operation?
Not too bad.
Are you in any pain at all?
Yes, but it's okay at the moment.
Okay. Did you need any pain relief?
No, I'll have it when it's next due.
Is there anything else you need at the moment? Maybe a bedpan?
Yeah, I would like to go to the toilet.
Okay, not a problem. I'll go get that one for you now.
Thank you.
Not a problem.
All patients who are able to ambulate with or without a walking aid should be encouraged to walk to the toilet and should be enabled to use toileting facilities as much as possible, especially during the day. A raised toilet seat is used to provide extra height to enable safety for transferring on and off a toilet.
Can I get one of those bottles to go to the toilet, please? Hi James, as we discussed with the physiotherapist, we might see how you go walking to the toilet. How's that sound?
Yeah, I'll give it a go.
All right, let's do it.
Thanks, David.
A urinal is only to be used at a bedside when the patient is supervised, and it is a part of the patient's multidisciplinary care plan. If the plan of care for toileting a patient overnight is a urinal, then the urinal must be utilised in conjunction with hourly rounding. Bedpans and urinals are never to be left at the bedside. By safely using the correct toileting device, together we can reduce the risk of falls, hospital-acquired complications, and injuries to patients and staff, while maintaining the dignity of our patients and avoiding longer hospital admissions. Supervise, supervise, supervise. Always try to stay with your patient in the bathroom whenever possible. Up to 80% of all falls occur in a bathroom or are related to toileting. Safe mobilising, understanding a patient's cognition, and toileting plan are an important part of enablement nursing and should be considered as much as other observations and assessments. For any other information on safe mobilising and enablement nursing, or any other patient care essentials, go to the Hunter New England intranet homepage and click on the Excellence site, or write to the email on the screen.
Thank you, and sorry I went over.
It's okay. He cleared that before we started. Thanks, Greg. That was a great presentation. And we do just have one question online. Were the pens customised? And I can say that yes, they're definitely customised, and they have the little pull-out that has some of the information that was on the presentation. So these presentations will be uploaded on the New South Wales Falls Prevention and Healthy Ageing Network website within the next couple of weeks, so you'll be able to see that there. And I'd just like to make reference to a slide of Greg's where he mentioned the QIDS data. So anyone in New South Wales Health has access to your data via QIDS. QIDS is a quality improvement data system. The only caveat is you just need to request access to the data section on QIDS from your clinical governance unit. It shouldn't be a major problem, but if you want to see your data on your wards for anything, you can have access to the data system on QIDS. Thank you. Oh, sorry, was there any other questions in the room for Greg? Oh, there's a couple over there.
So the question was, with looking into bathrooms, has it changed the referral process to... Look, I don't have definite data, but I can assume that because the conversation is talking and being spoken about, particularly from a comprehensive care lens, and that change of risk screening and care planning, and being the MDT member being able to contribute to that care plan, it makes it a lot easier, say, for an OT who comes, assesses the patient and then has particular care changes that they want, they can then put that directly onto the care plan. So it's sort of the perfect line-up of those aspects that has helped ultimately increase referral because we're talking about it, but also the ability to contribute to a care plan comprehensively as well.
Good afternoon. My question is
One of the strategy of a patient coming into the hospital, if they are a high risk of fall, the patient going to be put on a 4-bedded room, which is supervised by a nurse, and it's called a high falls risk room. Is there any data that shows that this room is effective? Because if we're going to supervise one, the 3 going to be left behind.
So I don't have that data on hand at the moment, but I'm assuming from a Hunt New England perspective, you're talking about the model of care that includes a close observation bay or one-on-one or enhanced supervision. So often with some of that data from my experience that I've seen as well, when you put your high-risk patients into a space, you can get a higher incidence of falls because they are falling. But ultimately, when it has been applied previously in Hunt New England, say at a ward level, there's been decreased amount of falls that have occurred based on increasing supervision. And that's a lot what we spoke about today, was that increasing supervision within the bathroom.
Thanks, Greg. Thank you.